طيب السلام عليكم. Good evening everybody and welcome to today's webinar, The Art of Anticoagulant Ramadan, which is organized by Saudi Cardiac Clinical Pharmacist Group, part of Saudi Heart Association Group, and sponsored by Pfizer. And I would like to thank both of them for the great opportunity that they gave us tonight. I'm Dr. Raad Al-Khatchan, I'm an interventional cardiologist. I'm very excited for our program today. Thank you for taking time out and being here tonight. I think we had over 500 people registered. So I'm going to wait a minute for the Zoom software to let everyone in. Okay, tonight we have a phenomenal expert speakers. We are grateful for them for volunteering their time. I would like to ask our speakers to introduce themselves. I would like to start with Dr. Mirvet.
السلام عليكم ورحمة الله وبركاته. كل عام وانتم بخير. شكرا دكتورة فخر and the Saudi Heart for organizing this. I'm Dr. Mirvet Al-Asnaj. I'm an interventional cardiologist and the director of the catheterization laboratory at King Fahd Armed Forces Hospital in Jeddah.
Welcome, Dr. Dr. Fakhr. Dr. Fakhr, if you please introduce yourself. I think everybody here know you.
Assalamu alaikum wa rahmatullah. The voice was disappearing. Can you hear me now?
Yeah. Go ahead.
Okay, thank you very much, Dr. Dr. Mirvet, for being part of our Saudi Pharmacy Group activity. I am Fakhr Al-Ayoubi. I am an intensivist cardiology clinical pharmacist. It's an honor, of course, working with the Saudi Heart as usual. My experience was most of it clinical practice. I like academia, I like research, and it's always a pleasure to work with physicians. We are one team in order to get the best out of everything. Thank you.
Thank you, Dr. Fakhr. So before we start, I would like to announce that we will be running a live question and answer at the end of talks. So we have enabled our question and answer features. So if you have any questions, please, during the presentation, type them into the question and answer box in your Zoom control down. And we will start our program today with the first part with Dr. Mirvet. So start, Dr. Mirvet, please.
Thank you. Okay, so I'm sharing my desktop with you. I hope you can see it. Can you see my presentation at this time? All right, Assalamu alaikum wa rahmatullahi wa barakatuh one more time. I was delegated to discuss anticoagulation for atrial fibrillation and its consequences from a cardiology perspective, as a cardiologist who sees patients in clinic. So the format is going to be, I'm going to run a few cases and then go over the data that justify the treatment strategy for each case. But why are we even concerned with atrial fibrillation? We all know a lot of our patients are actually asymptomatic. Very few come with palpitations or syncope or even ischemia. The dreaded complication is this little blob that you see here. This is a transesophageal echocardiogram that shows the left atrial appendage, and this is a 3D image, and this is a 2D image of a thrombus in the left atrial appendage. The most important complication is actually stroke and embolization just to anywhere else in the body, and that's what we try to avoid with anticoagulation. So let's start with the first case that I have for you. This is a female, she's 72, weight is about 74, blood pressure 140/90. She was asymptomatic and newly discovered atrial fibrillation that was incidental. The preliminary investigation, her TSH was normal, her echocardiogram showed only mild mitral regurgitation, and the current medications that she was on were atorvastatin and valsartan. So the referring physician was concerned because this patient is over 70 about bleeding with one of the quote-unquote novel anticoagulants and chose to give the patient vitamin K, VKA, a vitamin K antagonist, warfarin. But because of the COVID-19 lockdown, the patient was unable afterwards to come and get the INR done. So this is very practical and very real, and we see it a lot. A lot of people feel, for whatever reason, that warfarin is safer. So let's just go through the history of our anticoagulation protocols. So warfarin was studied against placebo. The total number of trials, around 6 of them. Total number of patients investigated were around 2,900. But if you look at what we call NOACs, or the novel anticoagulants, compared to warfarin, the total number of patients enrolled in the studies were over 71,000. And these were spanning across the next 10 years, so over a decade plus later. 2 decades later, actually, we have more data collected. So what are the direct oral anticoagulants, or the NOAC? Really, they're no longer NOACs. They're not new. We have about 20 years of data now. The common are the dabigatran, rivaroxaban, apixaban, and edoxaban. They're direct. All of them are direct factor 10A inhibitors, except the dabigatran. They all have some renal clearance, but elimination renal clearance for dabigatran is most. And if we look at the guidelines and how they have progressed to guiding us as cardiologists. So if you start in 2009, we started with the RELY trial, and then we moved on to ROCKET and so on across the years. But if we look at what guidance we had from the societies have actually been fairly conservative. So if you look at the American Heart Association with the HRS and the ACC, they continue to recommend vitamin K as recommended as their primary choice. The ESC, the Europeans, which are actually a little more progressive, in around 2010, when all of this started, they were recommending oral anticoagulation with PKAs. And it was only later that the Canadians were the first, actually in around 2012, to recommend NOACs over the vitamin K or warfarin. And it was much later that the ESC actually recommended NOACs as a preferred over vitamin Ks. So looking at all these trials, and as I said, there's a large sample in these patients. Dabigatran was assessed the 2 doses, and then rivaroxaban, apixaban, and edoxaban as well in 2 doses. Most of the trials were non-inferiority trials, and they looked at 2 outcomes. The primary outcome is an efficacy outcome, looking at stroke and embolization, and safety outcome, looking at bleeding across the board. The baseline characteristics were pretty much similar for all of these trials. You know, the women were around 35 to 40%, about 30 to 50% were naive, warfarin naive. The biggest difference really is in the CHADS-VASc score, and the ROCKET AF had the CHADS-VASc score of around 3 to 6%, or CHADS-2 at the time, was around 87% compared to the other agents that were evaluated. So really quickly going over these without boring you to death, the ROCKET AF compared rivaroxaban against warfarin. Again, the primary efficacy endpoint was stroke and non-CNS systemic embolization. And when you look at that, you can clearly see that rivaroxaban did better, and there were more events in the warfarin arm, and it was found to be it met the non-inferiority requirement for it. When you look at the primary safety endpoint, rivaroxaban, although numerically may have had more events, but it never really reached statistical significance, and hence they were considered similar. When you look at RELY, it looked at warfarin with the 2 doses of dabigatran, and this was actually adjudicated events for these. Again, the same thing, looking at stroke and major bleeding as the primary efficacy and safety outcomes. And when you look at dabigatran, both doses in terms of efficacy, they both fared better than warfarin. Obviously, dabigatran, the 150, had better than both warfarin and dabigatran 110. In terms of major bleeding, once again, dabigatran, both doses did not have more bleeds compared to warfarin, so it did meet the non-inferiority that was pre-specified. ARISTOTLE, once again, looking at apixaban, they looked at 5 milligrams twice a day, and they actually did enroll patients who were over 80, low weight, and mild renal dysfunction, and they reduced the dose to 2.5 milligrams twice a day for those. Again, this very similar primary outcomes of efficacy and safety. But with the apixaban, they were really the only trial that showed superiority, not only non-inferiority compared to the other agents, when it comes to reduction of stroke or systemic embolization, with a 21% relative risk reduction. And the same for bleeding. It was found to be superior to the warfarin, and again, 31% relative risk reduction. So apixaban is the only DOAC that actually not only was non-inferior to the standard of care warfarin, but it was actually superior when you look at 3 outcomes: embolization and stroke, major bleeding, and mortality. All of them reached statistical significance. But what does that mean to me as a clinician when I sit in my office and I have to decide on a patient like the one that I just described to you? I have to balance it, right? So I have to look at the efficacy of the agent. So I have to look at, is it favoring a NOAC or favoring stroke or favoring warfarin, I'm sorry, when it comes to efficacy. And when it comes to safety as well, I look at the major bleeding and I want to see, is it favoring NOAC or favoring warfarin? Now, keep in mind, there's one particular entity, GI bleeding, and we do see these quite often, actually. We see patients who have had prior history of peptic ulcer disease or prior history of bleeding. And what you do see is Apixaban, rivaroxaban, and dabigatran. Now, Apixaban, there was actually no increased bleeding compared to warfarin. Rivaroxaban did have, and it did reach statistical significance that it was more than warfarin, the GI bleeds. And when you look at dabigatran, particularly the 150 milligram dose, it was higher and it did reach statistical significance. So as a clinician, if I know my patient has significant peptic ulcer disease, had a GI bleed that required transfusion, admission, and so on, I would be very cautious on the choice of anticoagulant that I give this patient in the future. So at the end of the day, it's really balancing both efficacy and safety. So if we look at edoxaban, for example, 30 milligram, well, great. I mean, there's very little bleeding that happens with edoxaban. But now look at this in terms of efficacy. In terms of efficacy, so it's not very efficacious. And at the end of the day, you want something that's fairly balanced. And so you need to look across the board, something that's going to favor stroke and at the same time not increase your patient's risk of bleeding. So looking at this lady who had COVID era, she cannot come to get her INR done. So the chances that she discontinues her medications is actually high. And when you look at all the agents compared to warfarin, unfortunately, only Apixaban was the one with the least discontinuation, primarily because of symptoms. But I've also had patients who tell you, look, especially the ones that don't live in cities and have to travel a long way to come and get their INR done, they would much rather just stop and they actually end up quitting. And I had to convert these patients to one of the oral anticoagulants. So I'll move on to the next case. So this is a female, 68, weighs very little, about 47 kilos. Blood pressure is 170/85, mild renal dysfunction. Once again, she has chronic diagnosed established atrial fibrillation for 6 years. Her echo showed only mild to moderate aortic stenosis. And her referring physician, in view of concern over weight and frailty, and a lot of times we confuse weight and frailty and age and frailty. So we should be very cautious to label our patients as frail simply based on age or weight. But this physician put the patient on 81 milligrams of aspirin, so baby aspirin. So let's look at the data that drives that. So AVERROES trial, and I'll be honest with you, I was very early on in my career as a cardiologist when the AVERROES trial was published, and I was like, what is this trial? I mean, why are you even comparing aspirin, which is not an established medication is not an anticoagulant, period, to an anticoagulant? Then when I got into practice and had my clinic started to build up and it became more busy, I started to see that this is actually practice. It was a well-designed trial and it was important because this is what people actually do. They choose to put their patients on aspirin. They're afraid of bleeding and the medical legal implications if the patient bleeds. Unfortunately, you're not really helping this patient, not from a bleeding perspective or from a stroke perspective. So quickly, the AVERROES trial was again a randomized double-blind trial. Again, the same inclusion criteria and the same doses of Apixaban, 5 milligrams. Otherwise, it was 2.5 milligrams twice a day if their age or weight was low or mild renal dysfunction, against aspirin dose 81 to 324, and very similar outcome criteria. So stroke as an efficacy endpoint and systemic embolization, and then any form of major bleeding. The type of patients that were enrolled were ones that were previously received but discontinued their vitamin K antagonist for whatever reason, or they were unsuitable from the get-go for vitamin K antagonists. So they were VKA naive. And who were these VKA naive patients or unsuitable? Well, they're the ones that can't come in for regular INRs, exactly like the earlier patient that I had discussed. Or the patients were concerned about VKA, they refused the warfarin. And I have had patients come to me, even when I was still training in the US, telling me, but I heard this is rat poison. You're right, it is rat poison. That is what it is. But we try to give it in doses and we try to monitor it. And then the CHAD score was 1 and the physician did not recommend a VKA for whatever reason, particularly as our guidelines ended up evolving. So when you look at the results for these patients and you look at it reduces stroke or systemic embolization without an increase in major bleeding, as I said a minute ago. So if you look at the primary efficacy endpoint here, there's a 55% relative risk reduction. So really, if you're giving this patient aspirin, the cumulative event rate and hazard ratio is very high compared to Apixaban. So you're really giving them a placebo. So you may as well not give them anything and elect not to anticoagulate if this patient has a risk of fall and so on. When you look at major bleeding, they were fairly similar. There was no increase in bleeding. So giving these kind of patients Apixaban does not come at a cost at more bleeding compared to aspirin. And these are the bleeding endpoints. So they looked at both intracranial, extracranial, GI, non-GI, clinically relevant, but not major bleeding. Again, none of them reached statistical significance. So what did the guidelines say? So remember in the beginning, I said finally the 2016 European guidelines actually advised to go ahead. So they recommend that we look at the CHADS-VASc score for these patients. If it's 0, no antiplatelet or anticoagulant therapy. 1, consider oral anticoagulant, and 2 or more, consider oral anticoagulant, preferably a NOAC as we move along. So patients who cannot have oral anticoagulants for whatever reason, so we have left atrial occluders that you can just, this is a TEE and it shows an occluder, this is the occluder, but actually there's also a risk of having thrombus. These are thrombus forming on top of the left atrial appendage occluder device. And there are several trials that were actually published showing the safety and efficacy of these devices. However, remember that these patients, usually there's at least a 45-day run-in of anticoagulation. Which makes me wonder if it's actually really indicated. But in any case, even patients in whom you want to consider left atrial appendage occlusion, ultimately the recommendations keep telling you go back to oral anticoagulation if possible. So if the patient is suitable for anticoagulation, just go ahead and give them anticoagulation, preferably a NOAC or a DOAC. If the patient is at risk of bleeding, you still have to individualize it and talk about risk and benefit with the patient, involve the patient, make sure the patient is part of the equation and part of the decision. And if not, consider left atrial appendage occluder. If the patient refuses, again, discuss it with them and advise NOAC. So if they tell you, I don't want a NOAC, don't automatically consider an occluder device, but actually advise them that they should probably have it. So the recommendations for stroke prevention in AF, it's a class 1 recommendation, is actually a DOAC or a NOAC is recommended in preference to vitamin K. Patients with GI bleed, another DOAC other than dabigatran 150 and rivaroxaban is recommended, or actually edoxaban 60 milligrams. For patients like the one I told you, the COVID-19, if you are unable to maintain the INR in therapeutic range, there are a lot of patients where the INR tends to yo-yo, or you just never actually manage to get it in therapeutic range. So if you're unable to keep it in therapeutic range for long enough, then these patients, perhaps you should be considering one of the DOACs. Antiplatelet monotherapy is not recommended at all. Actually, it goes towards harm if you give these patients antiplatelet. So this is where you and I, Dr. Raed, this is what we see all the time. So this is a male patient, 70 years old, BMI approximately 28. Initially was asymptomatic, non-valvular atrial fibrillation on standard medications. The CHADS-VASc score of this patient was 2 based on the hypertension and the age. And this patient comes through the emergency room with this EKG. So this patient is having clearly ST elevations in 2-3 and AVF and inferior myocardial infarction. And the next decision comes now for the cardiologist to decide, what am I going to do? Am I going to do a primary PCI for this patient or lyse this patient because they're already on an oral anticoagulant, a NOAC? If I will progress and do a PCI, is it going to be radial and femoral? Or am I going to use a BMS or a DES, bare metal or drug-eluting? And if so, what kind of peri-procedural anticoagulation is safe to use in these patients? And what antiplatelet regimen am I going to give this patient afterwards? So let's look at this very busy slide, but I'll narrow it for you. So we have this patient with non-valvular atrial fibrillation on a NOAC, comes in with an acute coronary syndrome, not any acute coronary syndrome, but rather a STEMI. Preferred is actually PCI over fibrinolytic therapy. Radial access, preferably. You can give the patient additional unfractionated heparin or low molecular weight heparin. Avoid 2B3A unless absolutely necessary in these patients. So just keep in mind, you need to know what the patient's HAS-BLED score is as well to make your decision as you go forward, whether you want to continue with anything extra as the patient goes to CCU. whichever anticoagulant is available in your hospital and this patient is on, you need to also know what are the contraindications of other medications and just discuss it with your clinical pharmacist, and you see if there's any drug interactions. But the next important question is anticoagulation with dual antiplatelet or single antiplatelet. So once again, if you look at the EHRA guidance document, again, looking at our patient who had acute coronary syndrome, what's recommended is triple therapy. Now keep in mind that triple therapy, the risk of bleeding is certainly higher than dual therapy or monotherapy. Depending on how the patient is, they recommend for an acute coronary syndrome anywhere from 3 to 6 months of triple therapy followed by double therapy. And at 1 year, you continue with monotherapy of an oral anticoagulant. So if we look at the current body of evidence that's not published yet, there's plenty of studies that are now in the process of being published. One of them is the Master DAPT. These are randomized trials that are trying to have abbreviated oral, antiplatelet therapy. So, trying to give the patient 1 or 3 months of antiplatelet therapy, of dual antiplatelet therapy after the index PCI. So perhaps these will help us guide us in the future, but for the time being, the data that we have, and there is some data that is actually out there, the Pioneer AF looked at rivaroxaban against VKA and dual antiplatelet. Augustus looked at Apixaban against, and it was actually a 4-way trial. And the others were the Redual and Entrust. And all of these trials actually looked at the same thing pretty much, looking at triple therapy, dual therapy, and the risk of bleeding and safety endpoints. So it's clearly safer to have the triple therapy is actually not as safe. The bleeding risk is higher, but it is safe to continue with a NOAC and a single antiplatelet in these patients. And I think for the sake of time, I'm going to stop here and leave it to you, Dr. Raed, if you want us to entertain questions at a later time.
Yeah, thank you so much, Doctora. It's really amazing presentation, and really you summarized a lot of clinical dilemma. We had a lot of questions, but I think we will proceed to the second part of the program today. So we will come back to the question at the end of the talks. So now would like to start with Dr. Fakhr, please.
Sure. Thank you very much, Dr. Raed, Dr. Mirvet. It is very nice to talk about a local experience. And this study actually was done in our cardiac center. We were answering a very crucial question that we always face with our cardiac patients who want to fast and they don't want to miss Ramadan. To start with, of course, العشر مبارك عليكم جميعا وكل عام وأنتم بخير. عيد مبارك إن شاء الله للجميع لأنه اليوم حيكون the last webinar for the group. We will restart إن شاء الله after عيد. So إن شاء الله الله يتقبل منا جميعا يا رب الطاعة والعبادة. And to tell you why you are here, why are we tackling cardiology topics? It's always actually a challenging point when it comes to some medications that different specialties using it. You know that anticoagulant is not just a cardiology medication, it's hematology, family medicine, primary care, and so on. So what are we here trying to do? It's trying to make life easy. We are trying to talk about why do we have different agents, what's the difference between one and the other, what is the data about each one of them. Dr. Mirvet thankfully covered the very crucial part for cardiology. And of course, I want to tell you about our study that we did in our cardiac center and how can a pharmacist play a role, especially in the COVID-19 now crisis, where we had to do a point of care management clinic in order to cover most of the crucial questions that comes from the patient. We know that the Muslim population is increasing. As you can see now, by the 2030, we will be almost 6 billion around the world, which is a very huge number. And one, of course, of the most important thing is Ramadan. And fasting Ramadan, the thing that makes it difficult for us to understand fasting in Ramadan is that Ramadan doesn't come in a fixed time every year. We know that. Sometimes we have to stop fasting. We have to stop eating and drinking for sometimes 14 hours, sometimes 12 hours, sometimes it goes to 20 in some Scandinavian area, and so on. So the crucial thing about here is that what happens to a patient who has a polypharmacy medications and they have comorbidities and they still want to fast, and if they can't fast safely, why not, if we can help them in doing that? Most of our Muslim patients, unfortunately, they don't trust us regarding the fasting part. They don't want to stop fasting, we know that. And I saw lots of patients coming to the clinic in the heart failure unit especially. When we tell them that because of your health, you cannot fast, they start crying. And I understand, because if it comes to my father, my mother, even myself, stopping fasting is like telling them that you're back being kid again, or like telling them that, okay, you've done your part in Islam, so that's done, you don't have to fast anymore. Again, we don't want this to happen. We really want to help them in reaching the best outcome of fasting with a very safe travel in the fasting process. We saw some scattered studies, honestly speaking, but it was tackling the glucose, for example, diabetic patients. We saw some also few very small studies about the hypertension, the stroke, and so on, but nothing was actually answering this question for us, is that how can I give direct oral anticoagulant, which one is good for the patient, and how can I instruct the patients to fast and take it in a safe way? So what happened here is that first we had to understand the rhythm, the change of life rhythm during Ramadan. Now, you know that what happens in the normal days, we take breakfast in the morning, and then comes the lunch, and then the dinner. So that's the normal rhythm. But what happens in Ramadan, and again, we're not talking about a fixed Ramadan. Ramadan, as I said, comes sometimes in the summer, sometimes in the winter. So the sleeping time will change, as you can see. Even the meals, you will have two major meals, which is the sahur and fatur, and the difference between the meals, as you can see, it varies from one month to the other, from 1 year to the other, from one place to the other. So the change of the rhythm itself, it's a challenging point, because if you're not tackling the half-life of the medications, either you are overdosing the patient, or what's happening is that you're giving a drug that will not be covering the whole day while your patient is fasting. That's why we have to stop a while and say, okay, what will happen if the patient's going to take their oral anticoagulant? What I did, and my team, we'll talk about the team very recently, that they said, okay, for diabetic patients, for example, we were saying that we have a type 2 diabetic patients. We had 94 of them were fasting. Fasting, if I want to say this patient is fasting, he should not fast less than 15 days. This is according to the literature review. So if your patients fast 5 days or 10 days, they're not considered fasting. They have to be at least fasting half of the month to see the effect of pharmacodynamic of the medication on them. And according to this study, they said, again, only 32% of them were able to reach the target of glucose level. Now, the glucose level, you know that in diabetic patients, we face dehydration, thrombosis, hyperglycemia, hypoglycemia, but you can measure the outcome. And the most dangerous part, of course, is the dehydration and the thrombosis part, because this will affect also my cardiac patients, the AF patients. The point here is that dehydration with a short-term risk of ischemic stroke in patients with atrial fibrillation, that was actually the concern that we were looking for. Now, again, I'm telling this out of actually a literature review that we were trying to get, mimic some of the studies to help us answering the question. The point here is that the most crucial part of the AF patients is the dehydration, and this is a significant risk factor for ischemic stroke for patients who are adult and with AF. Now, we only found a Turkey study, they come from Turkish studies, and they said there is no significant difference between patients who are fasting Ramadan in developing a stroke with patients who are not fasting Ramadan. But what about if my patient is on medication? This is the crucial part. Now, we know that fasting, as I told you, is stopping food and drink the whole day, either from 5 to sometimes 9 hours or even more, as I told you before. The point here is that I want to talk about two things. We just want to differentiate between pharmacokinetic, which is how the body affects the drug, and this is usually this is thing that is unchangeable. If a drug is a half-life of 7 hours, even with fasting or without fasting, it's the same. The one that is really affected by fasting is the pharmacodynamic of the drug, which is how the drug affects the body. And this is what we are actually trying to tackle, especially if you are talking about medications that is excreted through the kidney, or they will be affected by the hemodynamic of the body. As Doctora was telling us, Doctora Mervet, about the different new oral anticoagulants, or now we call them the direct oral anticoagulant, we were talking about the bioavailability of these drugs and how they're affected with food or without food, and the half-life of it. That's why some of them are given twice daily or once daily. Now look at this, the twice daily products and the once daily products. Look at the half-life. Again, this will not be affected by fasting Ramadan. What is the problem here is the excretion of these medications are all birenal. So dehydration is an issue. The elevation of urea is an issue if we give these medications to the patients. The other thing is that if I'm going to put my patient on what we did, we have two agents in the center, which is dabigatran and rivaroxaban. We were trying to have one of the agents which is given twice daily and the other which is given once daily to see the effect of the pharmacodynamic of this medication on the patients. What we did, we had inclusion and exclusion criteria. It was the heart failure team. We had Dr. Shireen Dessouqi, Mr. Ahmed Hajna, Dr. Samha, and Dr. Wad al-Kathiri. They were all actually trying to gather information about the patients in order to get the proper sample size. As you can see, the aim was the effectiveness and safety of these medications during Ramadan to prevent stroke in non-valvular AF patients. We had all adult patients. We also had the CHAT score evaluated for those patients. We also had to make sure that the diagnosis is AF. The other thing, which is very important, patients should be fasting not less than 2 weeks. The other exclusion criteria were other patients who stopped fasting, or patients who had a renal problem, or the ones who are not fully diagnosed, and so on. The point here is that we had 140 patients. It was a full observational study, and it was giving these patients, putting them in two arms. As I told you, one which is the dabigatran, 110 milligram, not the 150, and it was twice daily, and the other one is rivaroxaban, which is 15 or 20 milligram, once daily. As you can see here, now this is the demography of the patients. They are almost similar in everything, but there was just a little change here, that the characteristics exceptions between the two arms is the myocardial infarction, a history of myocardial infarction were more in the rivaroxaban arm. The heart failure were more in the Ramadan. Aspirin was more in those patients, the one who were taking rivaroxaban. There was no difference, of course, in the stroke or bleeding between the two arms. This is actually a 2 years follow-up study. And the thing that we found a change in is that the level of hemoglobin in the dabigatran, actually it became better after they used the new oral anticoagulant in Ramadan, and improvement in the urea outcome, which is a little bit like telling us, okay, maybe fasting improved the lifestyle of the patients and the fluid intake, so it really improved the outcome of this medication. The other thing is that the patients who had more bleeding were very few. They were the patients who were taking non-steroidals or aspirin. So I will not consider this as because of the new oral anticoagulant, rather than it's the combination of the non-steroidals or the aspirin. So we can see that these drugs are really effective and safe to be used in Ramadan in non-valvular AF patients. The other indications of frequency, still we need to have more data and of course bigger sample size. But we can see that the main concern of our study is that we really prefer the ones that are given twice daily rather than the ones given once daily, because if you miss a dose of the twice daily, you are missing 50% only. While if I'm missing a dose of the once daily, I'm missing 100% of the dose, which is really very crucial, because patients in this case might develop the stroke or the complications. And that's why in our clinic, we had to hire a clinical pharmacist in the cardiac clinic First of all, to identify the patients who have a high risk of polypharmacy. The other thing is that they need to approve the treatment protocols in order to simplify the complexity of the medications for the patients. I know one of our colleagues were telling the patient, take this 3 times, take this once, take this twice, and so on. So you're not actually giving a real plan for the patient. Make it simple, make it easy to apply. Of course, drug-drug and drug-food interaction is the responsibility of the pharmacist. And it's very easy now when you compare it with the warfarin clinics where we had to stop patients from eating everything. The other thing is the dosing part, which is relating it to the kidney function, because we know that the doses of even the direct oral anticoagulant is changing according to the kidney function. And of course, the safety and efficacy. What is the outcome? I'm giving a drug to stop stroke, but to avoid bleeding. So there should be also a follow-up for those patients. There should be a lab results every other time to see what we're doing. It's not for the evaluation of the efficacy of the drug rather than the safety of the drug. And of course, the counseling part. Measuring the adherence of the patients to their medication is the responsibility of a pharmacist. I always say this, look at that. This is how the patients come to your clinic. Imagine if you just have to memorize with no background of what the medication is like, what's the dose of this medication, and so on. So what we really advise that please bring the medications with you to the clinic. The pharmacist will sit, they will arrange for the patients how to use their medication properly. Sometimes even we use something we call improvement adherence tools, like for example, this application, which we downloaded in the patient's mobile. We put the name of the drug, the dose, and the timing. And every month or every 2 months, when the patients come back to the clinic, we get the monthly report about their compliance to these medications. Because again, patients will, I'm sure, will forget 1 or 2 doses. So if you are able to remind them, you are really covering a very critical point of non-adherence. Not talking about the other complications where the patients do not want to take the medication. In summary, we really need to educate our staff and healthcare practitioners about the anticoagulant, because again, each one of us has their own practice, their own backgrounds, but we are still struggling. We still need more experts to talk about this part in the therapy, and of course the interactions with food and with drugs. High-risk patients should be counseled, should be supported with adherence tools to improve their adherence. Cost-effective modules now is the era. So we want to also conduct a cost-effective modules for those kind of medications in order to support the use of these medications in a new indications like the left ventricle thrombosis and so on. And a national guideline is highly needed in different indications, because I believe that if you have a guideline, you are really improving the practice, not less than 60 to 70%. This is actually to end up with. Thank you very much. And again, I'm open for any kind of discussion or questions.
Thank you so much, Dr. Fakhar. And really, I think you and your group wrote how essential the role of the clinical pharmacist, mainly on those kind of issues, and even how helpful the role of them in the clinics and even in a daily practice with those kind of patients. I'm really proud to see a data proved how things are going in our population. So really thank you so much for this great presentation. Thank you so much. And now to the third part of the program today with Dr. Muhammad. Welcome, Dr. Muhammad. And I think Dr. Muhammad will start his presentation with us now. Welcome, Dr. Muhammad.
Welcome. Assalamu alaikum wa rahmatullahi wa barakatuh. Thank you, Mr. Chairman, for kind introduction. Thank you, Dr. Fakhar, for your kind invitation. I would like to start my presentation without further ado, talking about non-cardiac indication for anticoagulation. As you know, the most common indication for anticoagulation is cardiac indication, particularly stroke prevention atrial fibrillation, followed by other indications like VT, angioside thrombosis, etc. So my objectives gonna be about journey of on new oral anticoagulant therapy or DOAC of a patient through different health setting, discussed in case-oriented and evidence-based approach, I will not cover clinical trials. I just gonna be practical use of DOACs in clinical practice, and I will base my recommendation on ACCP guideline 2016 for VT treatment. This is considered to be the latest because we are anticipating the upcoming VTE clinical practice guidelines from American Society of Hematology this year. So it's good to have an end to journey toward, but it is the journey that matters at the end. So I will start by talking about thromboembolic disorder categorized to arterial and venous thrombosis. The arterial, that brain like stroke, TIA, heart, acute coronary syndrome, AFib, which is the most common indication for anticoagulation, mechanical heart valve, arterial like peripheral arterial disease, aortic aneurysm, etc. Then we have, this is my bar talking about venous thrombosis that can be broken down to DVT, BE, and unusual site thrombosis, keeping in mind that DVT and BE or venous thromboembolism account for the vast majority of venous thrombosis, about 95%, more than 95% is venous thromboembolism. Then we have the remaining 5% or less is unusual site thrombosis. And we define very important unusual site thrombosis, simply any venous thrombosis that does not affect the lower limbs or the lungs. So anything apart from DVT and PE considered to be unusual site thrombosis. So the venous thrombosis, I already said the VT, DVT, and PE is the most common. Then we have unusual site thrombosis, talking about cerebral vein thrombosis, subclavian vein thrombosis, regional vein thrombosis, Budd-Chiari or hepatic vein thrombosis, inferior vena cava or superior vena cava thrombosis, and you have upper extremity DVT. Remember, upper extremity DVT is considered as unusual site thrombosis. Then we have the subclavian vein thrombosis. You can have inferior mesenteric, superior mesenteric vein, splenic vein, and portal vein thrombosis. It's very difficult to cover all these, indicate each presentation of unusual site thrombosis deserve one presentation or webinar. So gonna focus about venous thromboembolism. So talking about venous thromboembolism, DVT and PE, remember that DVT start usually in the distal veins, i.e. below the knee, in about the vast majority of cases, and about 25% of distal DVT, of symptomatic distal DVT, it might propagate and extend to the proximal vein. So we know that distal DVT is vast majority, about 90% of the cases, and about 25% of symptomatic distal DVT, it can propagate to the lower proximal vein, the femoral iliac, iliac vein. And if you have proximal DVT, the risk of embolization to the lung about 50%, 1 out of 2, in spite of absence of chest symptoms. It's not necessary to have chest symptoms to have PE. So this is based on clinical studies, and this is very important implication. So remember that distal DVT, sometimes if a patient is presenting with a DVT, classical DVT symptoms, and they do Doppler ultrasound and it's negative, it does not rule out DVT because might be distal, and we know the sensitivity for Doppler ultrasound below the knee is low, about 30%, but sensitivity of Doppler for proximal DVT very high, about 90%. That's why if you suspect a patient with a DVT with a negative Doppler, you have to repeat it in a week time. A week time, it will propagate the distal DVT to proximal DVT. And very important implication, what I said, that if you have proximal DVT, about 50% they have pulmonary embolism, because I just, one patient referred to me, a patient admitted with classical postpartum DVT, and after 3 days, they requested CTPA, and without symptoms, without clinical indication for CTPA. Remember, it's contrast, exposure to contrast, to radiation. What happened? It was positive PE. Then they labeled the patient as a breakthrough thrombosis. it's not a breakthrough. This is the initial representation of DVT, usually with pulmonary embolism, and they requested IVC filter, etc. It's not indicated. So just to understand, proximal DVT, 1 out of 2 of them, they have embolization to the lung. It could be showering multiple emboli, or it can cause one large pulmonary embolism, causing what we call obstructive shock. So about 10% of symptomatic PE, they can lead to death, and usually within 1 hour. This is what we call it massive pulmonary embolism. And we need to intervene by initiation of life-saving drug like thrombolytic therapy. So this is a very important point. DVT cause PE. If you have DVT with a stroke, you have to suspect what we call patent foramen ovale, because we're talking about non-cardiac indication. So you have DVT with patent foramen ovale. So the thrombus will go through the right ventricle, sorry, the right atrium. From right atrium to the left atrium, then will go to the systemic circulation, causing a stroke. I remember for VTE in a pregnancy, the most common leg affected is the left leg, because the right iliac artery crossing the left iliac vein, and we call it Maternal-like syndrome. Now, common complications of DVT, what we call, you have the acute complication of DVT is PE, then you have the long-term complication, post-thrombotic syndrome, as you see, and very important, what are the goals of treatment of DVT? Why we treat? We treat to prevent PE, the acute complication, and death. And we prevent the long-term complication like post-thrombotic syndrome or venous reflux and chronic thromboembolic pulmonary hypertension. So this is very important. This is the goal of, and again, prevention of the recurrence. So very interestingly, if you have a patient presenting with a DVT, if you give Adherence and you don't anticoagulate, you leave the patient without anticoagulation, 50% of them, they have a recurrence. And recurrence, usually the highest recurrence within the first month, about 50% and 20% in the second and third month. And if you give adequate anticoagulation, so you decrease the recurrence risk from almost 50% to less than 2%. So that's why you need to hit hard, hit early for a DVT, like antibiotic. If you have infection, hit early, hit hard. Very important history of now we are in the era of DUAC, direct oral anticoagulant, or non-vitamin K oral anticoagulant. This is a major revolution in the history of thrombosis. Actually made our life easy for treatment of venous thromboembolism as outpatient, single drug approach. We have, remember the 3 milestones for the anticoagulant drugs. Remember the first one, it was discovered the leech. So the leech, the saliva of the leech has anticoagulant, bivalirudin, herodin. That's why they use leech to prevent graft thrombosis. This is one of the old, medicine, but still used in the current or modern medicine. So heparin, you have IV heparin, 1930, then you have lomotil about 1980, then we have the 2002, the indirect factor 10 inhibitor like condabaronic, then we have the direct drug. So all direct drug like DUAC from 2010 until right now, and we have the direct 10 inhibitor like Apixaban, rivaroxaban, Adixaban, Apixaban, and you have direct 2 inhibitor like dabigatran. But very important, this is the direct approach. So we say direct oral anticoagulant because they are a class of anticoagulant. They have a common target. Like as I mentioned, direct 10A inhibitor. So direct 10A, which is sitting at the convergence of intrinsic and extrinsic pathway, or you have direct oral anticoagulant targeting 2A thrombin. Very important, this is advantageous. It can have predictable pharmacokinetic, pharmacodynamic, and decrease the risk of major bleeding. It's very interesting, and it was proven in clinical trials. We have numerous clinical trials. However, interestingly, the random approach or shotgun approach, like for warfarin can inhibit 2, 7, 9, 10. It's very interesting. It is still, effective therapy for certain indication like mechanical heart valve. For antiphospholipid syndrome, DUACs, they fail. and prevention of thrombosis. That's why the inhibiting multiple key protein decoagulation cascade, it's sometimes useful like antiphospholipid syndrome and mechanical heart valve. So direct oral anticoagulant failed in this indication. Vitamin K, so that's why vitamin K, still around and it will not die. So we need it for very important indication, difficult indication like mechanical heart valve and antiphospholipid syndrome. So limitation of vitamin K antagonists, you are fully aware about it, unpredictable response, narrow therapeutic window, slow onset, slow offset. That's why you need, overlap with rapidly acting anticoagulant. And very important, slow offset before surgery. You need to bridge the patient with low heparin. That's why with the DUAC, you didn't need to have overlap the drug with rapidly acting anticoagulant because it is has rapid onset at the peak after 2 hours. So this is advantageous. You do need routine monitoring, like for warfarin. Warfarin, you need monitoring with INR, frequent dose adjustment, warfarin resistance. Sometimes you have some genetic polymorphism. You require high dose. I have seen patients, they are requiring 30 milligram of warfarin because of the warfarin resistance, and you cannot switch them because the indication is like mechanical heart valve, numerous drug-drug interaction with warfarin. There are still some interaction with the DUAP, but much less, and numerous food drug interaction. This is with warfarin only. So there are three, approaches for VTE treatment. Classical approach, which is the overlapping approach between rapidly acting anticoagulant like heparin, anafractional heparin, or fondaparinux with the vitamin K antagonist. So we overlap them for 5 days until we reach therapeutic INR. Then we have the switching approach. This is very important. Switching, you use heparin for 5 days, then you switch to dabigatran or edoxaban. I have seen patients, they use heparin in addition to dabigatran for 5 days. This is associated with the high risk of hemorrhage. So this is both are rapidly acting anticoagulant, so should be switching approach rather than overlapping. Then we have single drug approach for Apixaban and rivaroxaban. So very important, this is a case, remember, if you diagnose a patient with VTE, it's not just a single step. You just prescribe anticoagulant and you send the patient home without follow-up. No, it is from the clinical presentation to diagnosis to, again, for treatment. Sometimes you need to hospitalize. You have to decide this patient need for home treatment or hospitalization. Do you need to give just anticoagulation or you need to give a thrombolytic therapy? If the patient on anticoagulant requires surgical intervention, what you need to do? How long you stop the drug? Do you need to bridge? Again, dental intervention, which is the most common intervention. What you need to do if the patient with infection, like tonsillopharyngitis, what you need to do in the clinic, and how to deal with complication. So if the patient presents with a DVT, the gold standard test is ultrasound, and for BE is the gold standard is CT pulmonary angiogram. And we don't do any more invasive pulmonary angiogram. This is what we have, CT pulmonary angiogram. Look at it. It is a mimicker of invasive pulmonary angiogram, which we used in the past. So it's obsolete, the invasive. So only we have CT pulmonary angiogram. And the patient, if you have a DVT, see, this is 2016. The DVT, the standard of care is outpatient management. And for BE, only home treatment for or early discharge to low risk BE, and I will tell you how we risk certify BE. So that's the recommendation for management. So for BE, how to risk certify, we call it simplified BE, pulmonary embolism severity index. So any point like age more than 80 or cancer or heart failure or tachycardia or hypotension or desatting, this is any point, it will give you, this is a high risk. So you need to hospitalize this patient. If no point from this is 0 points, so 30-day mortality risk about 1%. But if you have any point, the 30-day mortality about 10.9% or 11%. So that's very important. Very important point, subsegmental pulmonary embolism. This is very clinical dilemma. So do we need to anticoagulate subsegmental pulmonary embolism? Not. So this is very important. Patient subsegment. So what we mean subsegmental B? So you have, this is the pulmonary, if you can see clear, this is pulmonary trunk. Then you have here and sorry, this is the trunk is not clear here. This is the main, like right main. Then we have this is interlobar. Then we have here, this is what we call lobar artery. Then we have this is segmental. Then we have this is subsegmental. Here, this is subsegmental pulmonary embolism, which is peripheral. So if you have subsegmental pulmonary embolism, do you need to treat or not? So there are situations. So if you have a subsegmental PE without negative bilateral Doppler, i.e. the patient had only subsegmental PE without DVT and high risk feature for bleeding, like elderly patient. So clinical surveillance is recommended over anticoagulation. But if you have a patient who have subsegmental PE with DVT, so you need to anticoagulate. If you have subsegmental BE with a patient who have high risk for recurrence, like cancer patient, so you need to anticoagulate. Antiphospholipid, you need to anticoagulate. So it's like case by case basis, but generally speaking, we don't recommend subsegmental BE for treatment. I just use this metaphor. If you anticoagulate like elderly patient 85 for subsegmental BE, like you are cracking, a nut with a jackhammer. So this might cause bleeding rather than benefit for the patient. So there are Saudi clinical practice guidelines for VT treatment. And remember that if you have, like this is, we call it phlegmasia alba dolens. This is a massive DVT with, limb venous threatening gangrene. So you need to use catheter-directed thrombolysis. So this is very important. There are many modalities for catheter-directed thrombolysis. We have many like angiojet, we have mechanical. Very important, if you use this modality, so you should use in the acute phase IV heparin rather than DOAC. And after the intervention, it applies the same duration of treatment. If it is a provoked, you need to treat 3 months. If it is unprovoked, extended. It has no relation with the duration of anticoagulation. This is for a BE. If you have a BE with hypotension, systemic hypotension, i.e. systolic blood pressure less than 90, you need to use thrombotic therapy. So DOAC or VKA from the ACCP guideline 2016, they recommend DOAC over VKA or warfarin, except if you have the patient with antiphospholipid syndrome or cancer here. But the subsequent guideline, like European Society of Cardiology, yes, they also favor DOAC over VKA, and they mention that you can treat cancer also with heparin or rivaroxaban or edoxaban, because Apixaban just published a few weeks ago in a New England Journal of Medicine. So that's important. This is the properties of ideal anticoagulant versus currently available drug. So you need about oral, or this is more convenient for patient, no significant food drug interaction, predictable response, no routine coagulation monitoring, fixed dosing, no risk of heparin-induced thrombocytopenia, which is really good for the patient. I already mentioned you have 2 drug approaches, dual drug approach, and you have single drug approach like for rivaroxaban and Apixaban. And these are the switching between anticoagulant regimen. This is very important point when you switch from VKA to NOAC, the INR less than 2, immediate 2 to 2.5 immediately or next day. Usually in our clinic, if the INR 2.5 or less, I switch from VKA to DOAC. And if you have parenteral anticoagulant to NOAC like lumoxitibarine, this is very important. If it is like BID dosing, so for the next due dose for lumoxitibarine, you can use DOAC, and etc. For IV heparin, usually you should use it 2 hours before discontinuation of IV heparin, because the onset of action after 2 hours. NOAC to NOAC, you can immediately switch from one to the other. So important point, it was mentioned by my colleague that you have to educate the patient, because anticoagulant effect drop rapidly after 12 if it is BID dosing, or 24 hours if it is once daily dosing. That's why very important to educate the patient. Compliance as patient education is crucial. So you have to give leaflets and instruction at the initiation, patient safety and group sessions, and involve family members. And there is no clinical trial that say that BID or once daily is superior over each other. So both are effective, strategies, and have to discuss with the patient. Patient preference is very important. So this is education. You have to have education materials. You have to make sure about the renal dysfunction. So you have to know that the excretion for rivaroxaban 35%, for apixaban is the least renal excreted 27, and the bigatran is the highest about 80%. And so they have approved, if you have approved for creatinine clearance more than 15 for apixaban and rivaroxaban, and for the bigatran more than 30. And I'm not sure about doxaban. It is just recently introduced to the market in Saudi Arabia. So when you need to monitor renal function, so if the patient is normal renal function, GFR more than 60 once yearly, if it is the GFR, if the elderly more than 75 or frail, you can do it every 6 months. In our clinic, honestly speaking, we do these patients, we do see them every 6 months with routine lab like CBC, renal, and liver function test. That's I do it routinely for our patient for VT indication. So the contraindication, be careful if you have hypersensitivity to active drug, severe renal impairment less than 15, switch to warfarin, active clinically significant bleeding, condition with significant risk major bleeding like GI, ulceration, recent brain or spinal trauma, concomitant treatment with any other anticoagulant. Very important. Sometimes we don't need to combine DUAC with aspirin or apixaban. Many times, anticoagulant medication is adequate, but there are indications for compelling, dual antithrombotic medication. Concomitant treatment with any B-glycoprotein inhibitor, prosthetic heart valve requiring anticoagulant. This we cannot use it, and antiphospholipid. So these are the medications that interact, maybe or better. If I have, usually I consult clinical pharmacists in our clinic to make sure that the drug interaction with the DUAC is important, but the common, medication like anti-retroviral, anti-fungal medication, anti-TB medication, they do interact with the DUAC. The food, very important, just rivaroxaban that we use it, we advise the patient to take it with food to enhance absorption, like if it is 5 milligram BID, like in Ramadan, we ask to take it with the breakfast and sahur. If it is once daily, like we ask them, like 20 milligram with the breakfast. Other medication, apixaban, the bigatran, take it with food or without food. There is no, any interference with that. Duration of treatment, i.e. is not associated with environmental risk factor. We call it idiopathic. We treat indefinitely. So that's the duration of treatment, and always balancing the risk of recurrence without anticoagulation and patient and physician, preference is very important. So very important practical point, if the patient before planned surgery, this is rule, remember it. It has to be, we say 24 hours before and 24 hours after if it is low risk bleeding surgery. This is standard risk bleeding. If it is high risk bleeding surgery, we stop it 48 hours before and 48 hours after. And this is based on the surgery related, risk of bleeding. So high risk, like this is major cardiac surgery, orthopedic surgery, cancer surgery, urologic. And this is important, the low risk. So like upper, lower GI endoscopy. So this is gastroscopy, hernia, cholecystectomy. This is the list is long. But remember, this is, you stop it 24 hours before and 24 hours after. High risk, 48 hours before and 48 after. This is just to make it easy for people. So dental interventions, skin surgery, and cataract surgery, you don't need to stop anticoagulation. You should resume. Remember, if dental intervention, just avoid being in the peak, like 2 hours after the drug. We advise to have the dental intervention in the trough level, which is the least drug level. So do you need to monitor DUAC? We don't need to monitor unless you have serious bleeding and thrombotic event like breakthrough, urgent surgery, renal or hepatic dysfunction, potential drug-drug interaction, and suspected overdosing. Just important. That's when we say monitoring, mean measuring the effect of the drug and adjusting the dose. Here, what we say, this is a quantitative measurement of the drug exposure. This is the how to monitor for the bigatran. We have dilute thrombin time and carrying clotting time for apixaban, edoxaban, rivaroxaban, chromogenic anti-10A. We don't use PT, INR for monitoring of apixaban, edoxaban, rivaroxaban, although they are you will find them elevated in these patients. We call it sham INR, falsely elevated INR. It's not genuine or true INR. If you have bleeding, you just need a classical approach. There are direct antidote for these patients, like for monoclonal antibody for dabigatran, idarucizumab, or recombinant factor 10A, andexanet alpha. We use it for rivaroxaban and rivaroxaban and apixaban. And we have non-specific reversal agent. This is what I'm using available in our hospital for factor BCC, like Briplex or Octaplex. We use it for reversal of factor 10A inhibitor with excellent efficacy and safety. In all patients we have used, about success rate of reversal about more than 70%. If you have any like tonsil pharyngitis, you can use antibiotic with DOAC, no problem. Very important point that if you have a patient on warfarin, the least drug that interact usually cephalosporin, and you can use also amoxicillin. But augmentin, it has significant drug interaction. Just to conclude that patient journey on anticoagulant therapy through different healthcare setting, as you have seen, is safer with DOAC than vitamin K anticoagulant therapy. And really, I lived the era of vitamin K antagonist, and I lived the era of DOAC, and I see it is really more comfortable, more convenient for patient, for healthcare providers. And in the clinic, we see more patient like before. Before with VKA, we have more congested clinic, more disorganized. Now it is the flow is easy. And I think this is really the major revolution for thrombosis. Thank you for your attention.
Thank you, Dr. Mohammed. And actually, we start at the beginning with introducing everyone of the team, and I think at that time technical issues was there. So Dr. Mohammed is assistant professor of internal medicine, and he's consultant of internal medicine, thrombosis and vascular medicine, King Fahd Medical City. Thank you, Dr. Mohammed. It's amazing talk, really, and it's covered a lot of things. Personally, being cardiologist, most of the time we are dealing with the other part of the story. Informative lectures for me. Thank you so much. So now we will go back to the questions. So I think Dr. Mirvat already, she answered some of the questions. Some of them it's really interested. So maybe we will go through. One of the questions was regarding the NOAC. So are better than warfarin, but what do you think? Which of NOAC is better? So if we compare them head to head, and that question was from Prof. Mustafa Shimeri. So if you can answer, so people can hear the answer. I know you answered it already on the system.
Yes, so we don't actually have head-to-head comparisons, and we have to be very realistic. Every hospital is going to have its own formulary. Very few centers or hospitals are going to have all three NOACs. So for real practical purposes, you're going to have to see what formulary is actually available in your own hospital or individual hospitals. But if you have to individualize a decision, I kind of tried to walk you through it during the course of my presentation. So for example, the NOACs are not all the same. So if I have a patient who's had a prior history of GI bleed, for example, I know that I'm not going to prescribe something like a rivaroxaban. The data is clear there that the risk of GI bleeding is higher with rivaroxaban. So the point is tailor it to the individual patient. If you have the option and you're not restricted by the formulary of your own hospital, tailor it to the individual patient that you have. So there are some ongoing trials and there are some meta-analyses that were done, for example, in elderly or patients with renal dysfunction. And, you know, there's a lot of talk, for example, with renal dysfunction, that if a patient has a renal dysfunction, they were excluded, especially with advanced renal dysfunction, they were actually excluded from the DOAC or NOAC trials. That's correct. But for the record, they were also not studied for warfarin. So many people will, by default, give warfarin under the assumption that, well, they were excluded. But there's some data that was published in JACC in 2017 that actually is a real world data, and they looked at patients who had renal dysfunction and were still given a DOAC, and it was safe, and it was efficacious. So if I have to choose what anticoagulant to give a renal dysfunction patient, I would choose a DOAC over warfarin for sure. The calcification and so on, and the safety profile is very, very different.
Great, yes, I agree with you. So, Dr. Fakhar, one question asking about which NOAC you could prefer in a patient with chronic kidney disease.
Well, according to the data, as we all went through, Dr. Mirva and Dr. Sheaf, that it depends on which stage are we talking about in the kidney failure or the kidney disease. If it's a severe kidney problem, none of them. If it's from 15 to 30, as shown by the studies, the Apixaban would be the safest in this case with a lower dose. And this is the one available in Saudi Arabia. It's not available. So most probably it would be the Apixaban with a lower dose.
Great, and I can see that all the experts here so agree with you. Dr. Muhammad, one question asking about, is the size of stroke affect the decision of anticoagulation regarding use of which of them? And is there a preference, one better than other, or what do you think?
Just to make it clear, so for stroke prevention and atrial fibrillation, so this is the question. What's the best drug for SPAF?
Yeah, if a patient with atrial fibrillation who had a stroke already, so status post-stroke, that's what I can understand from the question. It was not clear.
Mm-hmm. Yes, let's say, so if it is post-stroke, so we don't initiate the anticoagulation immediately because of the risk of hemorrhagic transformation. Usually they start just aspirin after 5 to 7 days. If they repeat CT brain, if there is no expansion of the, like hemorrhagic transformation, they can use DOAC, either DOAC, rivaroxaban or Apixaban. They showed excellent efficacy and safety profile, but definitely it's not recommended to be started immediately. And sometimes, based on the size of the stroke, if it is mass initiation of anticoagulation more than a week. And remember, the daily risk of stroke is low, so it's safe to wait for a week or more.
Great, great. Dr. Mirvat, one question asking about those patients who are presented with ischemic heart disease and they are a known case of atrial fibrillation on NOAC already. Question is the duration of the triple therapy. I think you answered through the presentation about that, but if you could focus on that again for that question.
Right, so two ways to look at it. One, you have to look at the acuity of the case. So if it was an elective or staged PCI as opposed to an acute coronary syndrome, and how complex the intervention was, if it was a complex intervention, and if you were using first-generation drug-eluting stents or not. So very PCI-related issues. The guidelines currently say for a acute coronary syndrome, you continue triple therapy from 3 to 6 months, after which dual therapy, and these are the European guidelines. And at 1 year, you continue with monotherapy for life. Bear in mind that there are ongoing trials now for drug-eluting stents and antiplatelet regimens that are abbreviated. Several stent platforms are being tested with abbreviated antiplatelets in high bleeding risk patients. So elderly patients, patients who require anticoagulation for AF, for example. Those have not been published. They have completed the randomization, and probably in the next couple of years, we're going to have a lot of these coming out. And they will hopefully help us reduce that initial period of triple therapy.
Great, great. Dr. Fakhr, from the experience, from the evidence-based medicine, what about NOAC and LV? NOAC and LV dysfunction. Those patients with LV systolic dysfunction.
I think it's if the patient having indication for anticoagulation like VTA or unusual site thrombosis with LV dysfunction, they are doing perfect. I have, seen many patients in my clinic, cardiac patient with, non-cardiac indication for anticoagulation and doing perfectly well. Even it is off-label use LV thrombus. I have seen many patients with LV thrombus on DUAC, and they are doing perfectly well, although this is off-label indication. So I don't see any problem, but you have to make sure that renal function, okay, adjust the medication to renal function, and try as much as possible to avoid dual or triple antithrombotic medication unless it is strongly indicated, because I have seen bleeding, major hemorrhage in cardiac patient on triple antithrombotic therapy, and I've seen them like after 1 year of stent, etc. I think this is area we need to, like in the clinic, the clinical pharmacist, the cardiologist, or if they come to our thrombosis clinic, always we have to make sure there is whether we need to continue dual anticoagulant therapy or not.
I would just also like to add a point here. We have already scattered information from our centers, and I'm sure other cardiac centers regarding the DUACs. All of them are effective. As Dr. Shif said, we need to monitor the patient with an echo before and after, when you give, especially for the LV patients, because the target's supposed to be reached. You don't put the patient on it and just leave them without a monitor. That's the crucial thing. That's the key point of using such a medication. And I agree with you. Any one of them could do the job. It depends on the proper dosing and the proper follow-up.
Okay. Dr. Marvin, have you used the NOAC in a patient with LV thrombus?
I'm sorry, was that directed to me?
Yeah, I'm asking about the LV thrombus and NOAC. Actually, both of our speakers, they mentioned that they can be used as off-label, but I mean, as a practice, have you used that?
So it is an off-label use. It is actually mentioned in the AHA-ACC guidelines for TIA, stroke prevention, but it's mentioned as an alternative to warfarin. So it's an alternative to vitamin K antagonist, not as the preferred, primarily because we don't really have some data. There was a very recent publication, I believe, in JACC about use of NOACs in LV thrombus, and it wasn't favorable. So although many of us would have preferred, myself included, because it, once you have a patient who has completed their MI, you want a bed turnover and you want to be able to send your patient home. And if they have an LV thrombus and you're still going to start anticoagulation, particularly patients who are far away, you can't tell them just go home and follow up with the anticoagulation clinic. So a lot of the times we're forced to keep the patients an additional day or two in the hospital just simply to monitor their INR and send them off with a therapeutic range on warfarin. But I think the preliminary data is not promising in this area.
Great. There is a question here, and the one who asked, it's actually mentioned that to Dr. Rashid, a patient with DVT and non-valvular atrial fibrillation, which NOAC would you like to start?
I mean, there is no head-to-head comparison between the DUACs. And remember, the population, they have different inclusion criteria, and they have different, clinical characteristics. Maybe there are some, studies have high-risk patients, some they have intermediate risk or low risk. From my clinical experience, the most common two DUACs I have used, Apixaban and rivaroxaban for treatment of venous thromboembolism. If one of the speaker, mentioned if a patient with high risk for GI bleeding, you might favor Apixaban because rivaroxaban can increase the risk of GI bleeding compared to Apixaban from clinical trials and from clinical practice, from our observation. So it's case by case basis. If the patient is really willing to use drug that once daily is strongly motivated, so you have to discuss with the patient the options, the pros and cons, but there is no one drug is superior to the other drug. the two DUAC are fine for me, but important, it's just check the duration. If it is a provoked, treat for 3 months. Don't extend anticoagulation duration.
Okay. Another question, Dr. Amir, but regarding the role of anticoagulation in a patient with atrial fibrillation status post-ablation therapy.
Yeah, so ablation for atrial fibrillation, I'm assuming that's the ablative therapy. So the success rate for ablation varies from center to center, but generally it is not 100%. It's generally in the area of 60 to 80%. So before taking patients off anticoagulation, you need to make sure that they have actually been cured. And so what we do in our center is after the ablation, we keep the patients anticoagulated for at least 6 months, and then 3 to 6 months, and then the anticoagulation is discontinued if no recurrence happens.
Great. Another question, Dr. Fakhr, about the timing. What's your advice regarding timing of the doses of NOAC if it's BID during Ramadan, while we know that the duration can be more than 12 hours?
That's a very nice question. That's what we stated it in the Saudi Heart Association site about using DUACs in Ramadan. And you know, the difference between futur and sahur is almost like 12 hours. And what's happening is that we tell the patients you should take it not less than 10 hours, but not more than 14 hours. That's the key point. Again, we cannot tell the patient that if you miss a dose, you just go ahead and you just skip it unless there's a space of taking it again. What I mean, most of the time we tell them take it in fatur, which is most of the time all of the patients will take it. Now the other one's supposed to be after 12 hours, but even if it's 10 hours, no problem, at least for the fasting area. After that, some of the patients, they come and say, I remembered after khalas, sahur, like he's already fasting. I can't tell the patient, well, okay, break your fast and take it. What we do usually, we say, khalas, once your fatur again is coming back, you take it. This is how we advise the patient.
Great. Dr. Muhammad, one question regarding one of the attendees asking about a personal case that the sister had an antiphospholipid syndrome and she's taking warfarin. So the question is, can be on NOAC?
Yeah, that's a very important question. We know that antiphospholipid syndrome is heterogeneous syndrome, i.e. You can have antiphospholipid syndrome with single positive antiphospholipid antibody. You can have dual positive antiphospholipid antibody. You can have a triple positive. There is clinical implication for this triple positive antiphospholipid syndrome, like positive anticardiolipin, anti-beta-2 glycoprotein, and lupus anticoagulant. If the 3 antibodies are positive, this is what we call full antiphospholipid antibody profile. This is a high-risk group of patients. All of them, they fail DUACs, and the drug of choice and the standard drug and the safest drug is vitamin K antagonist. Regarding single, positive antiphospholipid antibody syndrome, I have a patient in my clinic doing perfectly well more than 5 years. For dual positive, I can say this is again, it is like intermediate risk group. So let's take it for clinical studies. They have conflicting results for clinical trials. You have the latest one in published in Annals of Internal Medicine. They mentioned that rivaroxaban, like DUAC, is not inferior to vitamin K antagonist. However, there are previous studies showing that rivaroxaban or fail in the prevention of VTE. So you have conflicting, result. But remember that Saudi FDA, they have, sent memo for all physicians practicing, thrombosis to sign that not to use DUAC for antiphospholipid syndrome because of the risk of recurrence. Let me tell you about my own experience. I have used DUAC. We have like a clinical study. We use DUAC. Like rivaroxaban for antiphospholipid antibody syndrome, about like 40 cases, and I have seen cases. I said triple positive have highest recurrence. If they have recurrent VTE, before starting what have risk high thrombosis and sometimes they can get recurrence after 1 year or 2 years. I will be so I decided to use VKA for all patients, all antiphospholipid antibody patients, just to be in the safe side. So this is my recommendation. Do not use VKA for antiphospholipid antibodies.
Dr. Raed, you need to unmute.
Oh, sorry. Dr. Muhammad, regarding the COVID-19 and the risk of thrombosis, any special consideration in relation to anticoagulation those group of patients?
Yes, we have created a protocol for VTE prophylaxis anticoagulation COVID-19. So this protocol was, made in collaboration with our clinical pharmacist, infectious disease consultant, and thrombosis. So we, based on the clinical, we have like tsunami of clinical research of COVID-19. So you have to be updated every day. You have publication. It's very difficult to cope with. So based from the literature, published about COVID and thrombosis, we know that COVID-19 is hypercoagulable state. This is a matter of fact, and you have seen many cases of thrombosis, arterial large vessel stroke, or you can have venous thromboembolism. So we said that all hospitalized patients with COVID, they should receive routine standard VTE prophylaxis, all of them. So this is number one. Then we say, based on the D-dimer level, if it is more than 4 to 6 times of upper limit of normal, if it is like elevated 4 to 6 times upper limit of normal, you need to give them half therapeutic dose. Like phenoxypyrin, not 40 enough, like half milligram per kg BID, like medic 40 BID or 60 BID. And if they have high index suspicion for VTE, but you cannot, perform confirmatory testing, you can use therapeutic anticoagulation. Typically, patients who have a pneumonia that is improving, like radiologically improving by X-ray, but clinical, there are more requirement for FiO2. So you need to anticoagulate. This is really, I have just last week, we have unfortunate young patient who was previously healthy, presented with massive pulmonary embolism, very massive obstructive shock and stroke, and test came to be positive for COVID-19, unfortunately, after the death of the patient. So really, what's the mechanism of a thrombosis? We think it is linked to the inflammation, cytokine release syndrome, and coagulation activation. That's why we have D-dimer is very high, in spite of the DIC marker low. Like you can have patient platelet normal, you have PT, ABTT slightly normal, but D-dimer is sky high. So it's very unique. We think it's like from pulmonary intravascular coagulopathy. It's very complex, but thank you for asking this question. I will prophylax all of them. Okay.
Great.
I just want to add a point, Dr. Raed, regarding this question. It's a very nice question.
Yes.
We found that there's also an interactions between the drugs given for COVID, the antiviral medications, and the anticoagulant. So also that is another problem. We are facing 20 to 25% increase in the anticoagulant efficacy on those patients. That's why we sometimes have to even advise for the factor 10, sometimes monitor if he's on the direct ones, or sometimes the full picture PT, PTT for the dabigatran one. But again, I really advise that, as Dr. Rashif's telling us, we have to monitor the levels, the efficacy, and the bleeding sites. Where is it, and what's happening in the COVID patient?
Last question, Dr. Marbat, one of the attendees asking, do you use any special measures to avoid radial thrombosis being interventionist?
Radial thrombosis?
Yeah.
Well, yeah, we give heparin up front, whether it's diagnostic or a PCI, whether it's an intervention. So we have to give heparin even for diagnostic cases. But actually, the most important is trying not to damage the radial artery as you're going in, and what we call patent hemostasis. So not completely occluding the radial artery to maintain a little bit of patency, but at the same time balance it against hemostasis. And those have actually, that in particular has shown that it actually reduces the rate of radial artery occlusion subsequently.
Thank you for all of you, and at the end كل عام وانتم بخير وتقبل الله صيامكم وطاعاتكم. I'm really so happy to be a part of this amazing webinar. Would like to thank the clinical pharmacist group out of Saudi Heart Association. Really, they were very active during this Ramadan. Really, thank you so much for this opportunity. Thank you for Pfizer for sponsoring this meeting. And thank you for our great attendees. Some of questions actually not answered. We will try to answer it offline, inshallah. Thank you so much. وليلة سعيدة لكم جميعا إن شاء الله.
Thank you very much. Thank you.
Thank you.
See you after Eid إن شاء الله.
إن شاء الله حفظكم الرحمن.
السلام عليكم.
يا الله. وعليكم السلام.
السلام عليكم.